sort of the lessons I've learned along the way and really continue to learn. And I think that's the other thing. It's really important to approach this with humility, recognizing that it's dynamic and it changes all the time. So I have no disclosures to report. And, I think just to start off with, we all sort of understand the basics of genetic testing. Of course, it's, the purpose is to do analysis of genes associated with a phenotype or a clinical condition in an attempt to identify an inherited cause of, in this case, an inherited arrhythmia. Can help with, of course, diagnosis, medical management, and really identification of at-risk family members. And the thing is that historically, genetic testing has been kept in the hands of cardiologists with expertise in genetics, also medical genetics and genetic counselors. But our access to genetic testing is evolving, and it's evolving very, very quickly. And with that, it's going to be really important for non-genetics professionals, non-genetics cardiologists, to have an understanding of how to interpret these results. So I kind of like to think about it like this. Way back in the day, genetic testing comes along and we say, hey, isn't this great? We have a phenotype, we can do some analysis, we'll find a mutation and we'll have ourselves an answer. Lovely, going to give us all the information we need. We all recognize, anybody who's ever ordered a genetic test, seen a genetic test, this is actually more what it's looking like now. So of course, we can do genetic analysis based on a phenotype. Not uncommon that we end up with something that has a lot of letters and numbers associated with it and some words that are sometimes meaningful, not always meaningful. I hear from colleagues all the time how challenging they find it to read through a genetic test report. This is Latin, all of those sorts of comments made. So it really does raise a lot of questions. And of course, that is because we know very well that not all gene variants cause disease. I will tell you, in my years of doing this, it may seem straightforward in some respects, but to this day I get weekly phone calls about, well, we have a gene mutation, therefore it must cause an issue. And it's really tempting to want to do this. We all want to do this. We want certainty. But we have to consciously and consistently recognize that that is not the case. We can never assume that an identified gene variant actually causes a disease. And results of genetic testing have to be interpreted, and this is the other thing you're going to hear me say many, many times today, has to be interpreted in the context of not only the objective evidence that we have about the gene and the variant, but the individual in front of you, how they present clinically, and what their family history is. And we're going to walk through some of this today in a way that I hope is a little bit practical in terms of just how to think and how to think about these results, how to think about these variants, and how to work through them for your each individual patient and family. So anytime I'm given an opportunity, I'm going to spend 30 seconds talking about this, which is genetic testing. Yes, it is a blood test. It is very easy to send your patient to a lab to get that blood test, but it is much more than that. It is not just a simple blood test. And I have patients and colleagues, physician colleagues, you say, well, what's the big deal? Just go have blood drawn. We'll just get a result. It's fine. But that in actuality is not how it plays out. We know that the results of a genetic test are not binary. They can sometimes give you a pretty clear answer in the direction of a clear genetic cause. So if a genetic test result comes back positive, we have a decent answer, but they aren't binary. It's not yes or no. And often they come back as more of a maybe, we're not sure. We have to kind of wait and see. The other thing is that another thing is that, the results of this testing really can have very significant impact on your patient, their management, the risk assessment for them moving forward, as well as their family members. And if we get it wrong, it can result in serious mismanagement and significant risk. So we have to always have that in the back of our mind. What is the impact and the implication of our interpretation of this information? And because of that, I think it's really important to manage the expectations of ourselves as providers, but also the expectations for patients. So we're going to walk through a little bit of, practical practical suggestions. I'm going to call it advice, but I'm practical guidance on how to interpret genetic test results. And I put this little girl up in the corner because anytime I open my mouth about interpreting genetic test results or variants, I inevitably get the same reaction, which is her. Everyone puts their head on their desk and says, I don't want to do this. So hopefully by the end of this 20 minutes or so, you'll feel like you have a few practical tools to be able to do this. So the first thing that we always have to remember when it comes to interpreting a genetic test result is back to that statement where I said it's not a binary yes or no. All genetic test result interpretation is probabilistic. Okay, so we end up with classifications of genetic variants that go all the way from benign, so not disease causing, to pathogenic. But really what this is subjective terminology that is used to define an actual probability that a variant causes disease. And this has been designed by a very large group of experts in genetics and genomics to sort of come up with evidence categories, how we put things in these boxes. And I'll talk a little bit more about that later. But from this sort of first line perspective, when we think of something being likely pathogenic, I don't think that many people actually assign a number to it. Likely pathogenic in this context means that there's a 90% or higher chance that this particular variant causes disease. Flip side is if it's likely benign, it's greater than 90% chance that it's benign. But that leaves us with a giant black box in the middle, right? That means that a variant of uncertain significance that you see actually is associated with anywhere between a 10 and 90% chance of causing disease. So this is a spectrum, right? And I think that it's really, again, important to recognize that some of those variants of uncertain significance are ultimately likely causative of disease. We just don't have enough evidence to get it there. Some of them are likely benign. And there is just such a high degree of uncertainty within that box. And this causes us a ton of challenges, both from a clinician perspective and a patient perspective. So for clinicians, those of us that are ordering the testing and speaking with patients, it's challenging to know, like, what is the actual clinical relevance of this variant, right? And how do we communicate this degree of uncertainty to a patient? On the flip side of that, patients have to understand and appreciate that there's this uncertainty. And that isn't always easy for people to do, especially when they're dealing with lots of other, highly charged medical issues around inherited disease, in this case, of course, inherited heart disease. So we have a toolbox, and we have to always keep in mind that we have these tools that we can pull that can help us give a little more context to these results that we're seeing. And it does involve things like objective levels of evidence, which we'll talk about, detailed phenotyping, and I cannot speak about this enough, how important it is to have good phenotypic information about your patient in order to appropriately interpret that test result. Their family history, and of course, past clinical experience is always going to play a role here. So, using that toolbox, it becomes important to ask certain questions. So when we're interpreting genetic test results, you want to think, what are the questions to ask? What do I need to think about? And these are the questions to ask. We're going to work through these a little bit this afternoon, but you have to be thoughtful about, is there evidence that this particular gene that I have a report in, is there evidence that this gene actually causes any kind of disease? Because again, we would like to think that every gene that is put on a panel of a test that we are ordering for a patient in a specific clinical scenario has a direct relevance to that condition. Unfortunately, over time, there's just been an evolution of sort of a bigger is better mentality. And so sometimes there are genes that are analyzed as part of genetic testing, commercial and clinical genetic testing panels that may not have as much evidence for disease causation as you might think. And then the next question is whether the gene causes the disease of your patient, right? So does the gene cause any disease, or is it associated with the clinical presentation of the person you're testing? And how strongly is your patient's family history consistent with the finding that you're identifying on the genetic test result? So I'm going to talk about this in the setting of a case example. And this is a pretty common scenario that we might see in the inherited arrhythmia clinic. A 35-year-old woman presents with a history of recurrent syncope. She had an ECG which shows some borderline QT prolongation at rest. And so genetic testing, was sort of ordered in the community. And then a result came back, and she was told that she has long QT based on her resting ECG, as well as the results of the genetic test. And from there is referred to the inherited arrhythmia clinic for additional testing, review of results. When we dig into the family history a little bit, there are some interesting things here that we see. We have a sister that died suddenly at 42, although no autopsy was done. And so we don't really have a sense of what caused that. And then she reports a nephew who has some sort of arrhythmia and is being followed in cardiology. So here's the results that come along with her, referral. And the first thing you'll see is that there's sort of a large-ish, well, not that large, actually, a small-ish panel of genes that are tested in association with the long QT syndrome panel, and we have two variants that are identified. They're both formally classified as variant of uncertain significance, so anywhere from 10 to 90% chance that this does or doesn't cause disease. But you also, in this sort of type of report, can see some leading language, and it talks about the different phenotypes that can be associated with this gene. So with the ANK2 gene, it says cardiac arrhythmia, long QT, KCNH2 gene, a bit better known gene associated with short and long QT. You see words like probably damaging, you see disease causing, you see possibly damaging. This is challenging to interpret for someone who doesn't see this all the time, right? So let's work through this a little bit, because it's really easy. Again, like I said, people want to have certainty, and they want to have an answer for people. And so it is very easy, I think, for someone to see a result like this and say, well, we have genetic findings, we have a positive genetic test result, and I've seen it. So we have seen in our clinic where patients have been told that a result like this is positive, confirms a genetic cause, and sort of things snowball from there. But let's take a closer look at this. So in those questions that I talked about, we know the right questions to ask. So is there any evidence that this gene causes a disease at all? And does this gene cause a condition that is consistent with the patient sitting in front of me? So this resource here, these are hard questions, and it's laborious to try and yourself go through the evidence that's published about any given gene and its role with disease, aside from the ones that we know very clearly, like our KCNH2, which we'll talk about, or KCNQ1 for long QT syndrome. A lot of times you're going to get results on genes that you're not that familiar with. And it is difficult to be able to comb through the evidence that exists to know whether or not that particular gene causes disease. So this organization is called ClinGen. If you've done any work with genetics, you're likely somewhat familiar with this group. It's an NIH-based organization across the spectrum of genetics, and they sort of gather international experts to do some of this work for us, to evaluate objectively the evidence that's associated with specific genes in the context of specific phenotypes and specific conditions. And they've worked to put together a framework to assess that evidence and develop standards for how we can then assign categories of disease gene associations. And it's it's a rigorous process. I'm not going to go through all of it today, but what we end up with are publications like this one. And this was the ClinGen group specifically looking at genes associated with long QT, genes that are identified or present on gene testing panels, and what kind of evidence is really available and allows us to determine whether that's actually a gene that causes long QT syndrome. And what you see is that here, this is sort of how many long QT panels have these genes on them, and then based on the color, how much evidence there is to suggest that this gene actually causes long QT syndrome. And what we see is that many of the genes that are associated or that are on long QT syndrome testing panels don't have, at this point in time, great evidence for disease gene association. And so that's where we're going to start, right? So we look at, for example, our ANK2 gene, and this objective evidence suggests maybe it doesn't really have good evidence that it's associated with the disease. The next thing that they've done for us, which is great, I use this website almost daily, is that if you put ClinGen into a search engine, the first thing that comes up is a searchable database. And you can actually input your gene of question into the search bar, and it will tell you if it's been curated by an expert panel and what the disease associations are. So I'm going to do this here quickly for both of the genes that were identified in our particular patient. The ANK2 gene has been curated for a number of phenotypes, 3 of them being inherited arrhythmia syndromes. And what you see, Brugada, long QT, and CPVT, it's considered disputed. It is considered to be essentially no evidence that this gene is associated with any of these inherited arrhythmia syndromes. It is definitively associated with intellectual disability. So yes, it does cause a disease. Does it cause our patient's disease? Already we can start to say probably not. Conversely, here we see the KCNH2 gene. This is a very well described gene. We all know that this gene causes long QT syndrome. And of course, that is what is reflected here in this particular gene curation, also definitively associated with short QT, not Brugada syndrome. So this gene, again, anybody that is familiar with arrhythmia syndromes is familiar with KCNH2. So I just sort of put it there as a contrast, right, between a gene that doesn't have good evidence, a gene that does have good evidence, but how they're both reported as variants of uncertain significance on a genetic test report. So there's our questions. Is there good evidence that this gene causes any disease? Yes, they both cause some disease. Do they cause our patient's condition? ANK2, certainly, almost certainly not. KCNH2, yes. We know that KCNH2 causes long QT. But we also have to be really thoughtful about the presentation of this patient in front of us, right? So like I said earlier, not all gene variants cause disease, even in genes that can be consistent with your patient's clinical presentation. And this is where I'm going to put in a very large plug for Dr. Hansom, Dr. Green, and their colleagues with expertise in inherited arrhythmias, because how convinced they are that a patient has a clinical condition impacts how we're ultimately going to think about a gene variant that we've identified, right? And so in this particular case right now, I would say this patient hasn't seen one of the inherited arrhythmia specialists that we know have expertise in diagnosing these conditions. All we have is a borderline QT interval on a resting ECG. And that in and of itself, we know is doesn't confirm a diagnosis of long QT syndrome. So always we have to take that into consideration. So the next thing, so we've looked at our gene level evidence. Now we have to look at our variant level evidence, right? So yes, we know that some variants cause disease, other variants don't cause disease. How do we make that distinction? How do we determine that? And there is, again, this is a very lengthy document and a guidance document that was published in 2015, sort of commonly referred to as ACMG guidelines. And you would likely have heard or possibly have heard or seen that if you're talking about genetic testing interpretation at all. And ACMG guidelines, again, a group of very knowledgeable genetics professionals who've sort of evaluated the evidence that exists to decide what causes us to, or what types of evidence do we need to say this is likely going to cause disease. And it runs the gamut from things like population prevalence, for what, to some extent, what do in silico prediction models say, although we have to be cautious about that. Has this variant been identified in other people that have a clear clear phenotype of a specific condition. And then it's sort of all these pieces of evidence are weighed. There's strong and there's medium. And we call this altogether ACMG guidelines. I always like to think of it like this. I don't know if anybody, if I'm pretty old, so to think about the Pirates of the Caribbean and it's pirate code. And very funny says, you know, it's not actually a rule, it's more like a guideline. And I really think about this a lot in the context of our ACMG guidelines, because I think that it's really tempting, again, to believe or to believe that, you know, this is a very rigid set of rules, and once it hits a certain threshold, that is what a gene variant is classified as. But there is so much subjectivity to how these guidelines are applied, and this is why we also see discrepant classifications across labs, right? So sometimes you'll find a gene variant that is reported as a VUS in one lab, as pathogenic in another lab, which again highlights for me the importance as a clinical provider to always be critically evaluating what I'm seeing on the paper. This is just sort of some publicly available resources that can help you look at some of those evidence criteria. You know, the NOMAD database looks at the prevalence of variation in ostensibly healthy people. We use PubMed, of course, which is just our literature reviews. There are some online tools that can give us a good starting point. You can input your variant and it can kind of curate these evidence classes for you. And then ClinVar, which is a searchable database, again, part of that ClinGen organization, where laboratories can submit their classifications. But I will always caution with this particular resource, just be careful and thoughtful about what you're seeing. It can be discrepant. It depends on how a lab is using the ACMG guidelines, how they've modified the ACMG guidelines to meet their needs. So all of these are starting points that have to come in to play when you're looking at it in the context of your patient. So coming back to these variants, is there evidence to suggest that this variant impacts protein function or causes disease? This is the type of evidence we look for here. I won't go into it. Basically, there's not convincing evidence in either direction on a variant level. And is the family history consistent with this finding? So for ANK2, I mean, for cardiac, it's not applicable because we know that this isn't a cardiology or cardiac condition causing gene. Not applicable. There's no intellectual disability in the family. We can start to take this variant and move it towards that likely benign class. KCNQ1, whoops, wrong one. KCNH2, that was the variant. We have to, again, think about this in the context. What does that family history actually mean? So this is by patient report, what we're seeing here in the family history. And this is where, again, the expert EPs, the people that have expertise in diagnosing these conditions are really, really important, because depending on what we actually see, for example, in this young person that has an arrhythmia, does it look like long QT or is it something unrelated? You can't make assumptions, and we have to recognize that comprehensive phenotyping here is really important. Always when it comes to looking at family histories and, quite frankly, probands, clinical evaluation first, genetics comes maybe, right? So when you're looking at a variant of uncertain significance, if you have another person in the family that has a very suspicious phenotype for that particular gene, then yes, you want to see if they carry that gene variant as well to see if it's tracking in the family. Just going to leave that one for now. So the last couple of things I just want to touch on really briefly, and I think this is really important. As someone who works both clinically and a laboratory setting, I think it's really important to recognize that interpreting genetic findings is a shared responsibility, right? There are things and there are tools that the lab has and information they can provide us as clinicians that is much easier for them to access than it is for us, but it doesn't absolve us of responsibility of checking, double checking what we see, but also here, putting it in the context of our patient, because the lab does not have the capacity to do that. They're not clinicians and they don't have that patient sitting in front of them. So we can take what we get from a lab and we can then put it into context. Just a reminder that negative results do not exclude a specific diagnosis. This was lip service for me for a long time. It was like, oh, negative genetic results don't exclude anything. Oh, sure, whatever. I know better now. Absolutely, there are limitations to our technology, so we have to be careful. And variant classification can change over time. So it is dynamic. We know that the evidence changes. We recognize that what was once considered pathogenic can go down towards VUS or even benign, and it can go the other way. So, when it comes to interpreting genetic test results, I think what's really important to recognize, it's one piece of the puzzle, right? A genetic finding is one piece of the puzzle, and it is about more than what's written on that lab report. It has to be put in the context of a clinical phenotype that is comprehensively done and a family history of people who have also been phenotyped properly. The interpretation of any of these findings is probabilistic. It can evolve with time and with new evidence and with your patient's evolving clinical phenotype. And there are going to be times that it becomes really important to engage with experts in the field of inherited arrhythmias for sort of putting some of these pieces together. So hopefully that's given you a bit of an overview or a starting point anyway for how to think about some of these things. Thanks so much for your time.
Thanks, Mel. Fantastic as always. Very, very, very comprehensive. I think quick question from my side. Things have changed a lot, haven't they? The routes that people now are taking to obtain genetic information on themselves is really diversified. And we do see increasing numbers of people, for example, having occupational genetic testing just routinely, who are then, we're finding these variants sometimes pathogenic, and then being asked, what do we do? And this is posing kind of increased challenges. I think Dr. Green and I definitely are phenotype driven, but again, that's also changing. So what do you see kind of moving forward now as the landscape changes?
Yeah, it's a great question. So that whole issue around proactive testing is what they call it, right? So testing people who are curious about their risk, identifying pathogenic or likely pathogenic variants in cardiac genes specifically. We still have to drive it phenotypically. We see a lot of this in our clinic, a lot. And it's not an ideal way, we don't think now, of using our services, but we have to do it. What we're finding is that people who don't present with a phenotype don't have a phenotype. And that's been a really interesting thing. And so we have to be aware of that moving forward. As important as genetic risk is, and it is, we still aren't going to be able to interpret that outside of a specific phenotype, right? I think we're going to have to teach people to do a bit more phenotyping outside of our core centers in order to sort of maintain the expertise or give people access to what they need. I don't know. It's going to be interesting to watch it evolve.
100%. 100%. Again, just to encourage anyone else to, if they have questions, you can put it in the chat or you can raise your hand and we'll get to you in order. Dr. Green, Justin, any questions you want to
ask? Just a comment. I think that was a wonderful talk, Melanie, and I really enjoyed it. From my problem, the phenotype is the only thing I deal with. Mm-hmm. And you probably deal with the phenotype and genotype more than I do. But I'm just wondering where you think polygenic risk scores are going to go and whether we're going to be able to match multiple genotypes with phenotypes with polygenic risk scores.
I mean, that's a great question. And I would say I am in no way an expert in polygenic risk scores. It's sort of starting to be on my radar peripherally as well. I think it's going to be different for different conditions. So I still think there are going to be some of our classic, maybe not totally, but there's going to be some primarily Mendelian types of conditions where it is those single gene findings of strong effect. But there are others where it is going to be much more polygenic. We're certainly seeing this in Brugada, right? I mean, that's the classic one right now from an inherited perspective. And I think even with our long QTs, we do see some common variants that have some impact. And so I do think that with time, it will come to pass that there will be value to it. I think we're quite a ways from it yet. but I think it will evolve to that.
Fantastic. Thank you. Katie, are you online somewhere?
Yes. Can you hear me?
I can hear you beautifully. Yes, thank you. A special call out to Katie. So she's actually on holiday, and despite being out of the country and on holiday, she very kindly agreed to speak today. So I'm going to hand things over to Dr. Green, who's just going to briefly introduce her. But excited to hear what you have to say.
Thanks for being here, Katie. Thanks, Simon. So Katie is a genetic condition coordinator at the Office of the Chief Coroner of Ontario. I'm going to put in a little plug because I am incredibly proud of the work that our coroner's office does. One of the only jurisdictions in the world that is a bit like us is where Justin's from, because in New South Wales, they also analyze, they also do postmortems, they also try to figure out and are doing genetic testing on some of the decedents. Katie's role in the Chief Coroner's Office is really to connect us to the patients and the patient's family with the information. She supports the families and tries to answer their questions and is actually capable of creating a referral to the genetics clinics. She's an adjunct scientist at St. Michael's Hospital in cardiology, assistant professor at the Institute of Health Policy and Management and Evaluation at the University of Toronto. She has been an incredible advocate in sudden cardiac arrest advocacy, and a lot of the reasons, I think, why our coroner's office operates so well in this sphere. Thanks for joining us, Katie.
Nope. Thank you so much for the kind introduction. I can't seem to share my slides, so I don't know if you guys can share them on your end or.
Yeah, does anyone have that?
Katie, I do have your slides. If you give me a second, okay. I can bring them up and help you there.
No worries, thanks.
Oh, Seneda can do it. Seneda, are you there? I don't seem to have the privilege to.
Yeah, I was just saying, I think if you right click on her name, this is what I did for Melanie earlier. You can give her the privilege to share slides.
Yeah, it doesn't let me do it.
Let me see if I can do it.
Thanks.
All right, give it another shot, Katie. See if it popped up.
It did pop up.
Thanks, Alan. That's great.
Perfect. Can you guys see that okay?
Looks perfect. Thank you.
Perfect. Okay. So good afternoon, everyone. Thank you so much for the opportunity to speak today, for the kind introduction. My name, as I mentioned, is Katie Allan. I'm the Genetic Condition Coordinator in the Office of the Chief Coroner of Ontario, Ontario Forensic Pathology Service. So I'm really pleased to present for you today a little bit of an overview about our postmortem genetics program. These are my disclosures. So just a little bit of background. So in Ontario, our death investigations are led by the Office of the Chief Coroner of Ontario and the Ontario Forensic Pathology Service. These two organizations work together to provide high-quality death investigations and inquests, and to ensure that no death is overlooked, concealed, or ignored. The authority for all of the activities of coroners and pathologists in the province is derived from the Coroners Act. Deaths are investigated by physicians who are appointed as coroners or by other persons who are appointed by the chief coroner. Under the leadership of the chief forensic pathologist, registered forensic pathologists perform autopsies that are ordered by coroners. So the main purpose of a death investigation is to understand the how and the why that a person died. And oftentimes pathologists and coroners seek to answer 5 questions. Who, when, where, how, and by what means. The results from these death investigations are used to inform the strategic goals of the organization, which include supporting and informing next of kin and those affected by the death, improving public health safety, preventing further illness and death, and supporting the administration of justice. Section 10 of the Coroners Act defines the types of deaths that must be reported to a coroner. This includes deaths that occurred suddenly and unexpectedly. The majority of these deaths are investigated by a coroner. These are natural deaths usually, due to mainly cardiovascular disease, so-called sudden cardiac death or SCD. And we have guidelines in place to assist coroners and pathologists with the investigation of these deaths. So here's a screenshot of our SCD guidelines, whereby we recommend that all sudden and unexpected deaths in I should put young people in quotes, should be considered for a postmortem examination. So the main objectives for sudden and unexpected death investigations are to identify cases of potential genetic disease, obtain tissue for DNA storage, and inform next of kin about how to be referred to a medical specialist. So we have several indications for ordering postmortem genetic testing. If a heritable structural cardiovascular disease with demonstrated phenotype at autopsy is found, so these could include hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, dilated cardiomyopathy, thoracic aortic dissections, and premature coronary artery disease. When we have a death with a normal autopsy and non-lethal toxicology without an identifiable cause in both adults and children, so-called undetermined or unascertained deaths, we will order genetics. Other less common genetic tests that we order can include thrombophilic disorders, sudden unexplained death in epilepsy or seizure disorders, and any potentially non-cardiovascular condition that could be potentially heritable. So here we can see the number and type of postmortem genetic test requests. So this is internal to our organization that have been requested by people within the organization, mainly coroners and pathologists, between 2023 and 2025. So the most frequently requested panel is the inherited arrhythmia and cardiomyopathy genes, followed by lipidemias, connective tissue disorders, and hematology. Other consists of very infrequently requested non-cardiac genetic testing, such as hereditary cancers, primary immunodeficiencies, polycystic kidney disease, and others. So as you can see, the number of requests is increasing annually with a 30% increase since 2023. So my role, the genetic condition coordinator, was created in April of 2021 and became official in May of 2023, with a vision to be a resource for both the OCCO-FPS in the management of sudden unexpected deaths that are potentially caused by heritable disease. And the second, and I think more important role of this, is to really support those families after the sudden and unexpected death of a loved one, including answering any questions they might have, explaining processes or results, and most importantly, connecting the family to the appropriate clinical and supportive resources. So how do I become involved in a case? The most frequent way I'm notified is when the request for genetic testing is sent off by Dr. Chris Cunningham, who you may have heard of. He is our director of the postmortem genetics program here. The other most frequent way I'm notified is when the results of the genetic testing come back. Less commonly, a regional supervising coroner or an investigating coroner reaches out about a case and asks for my involvement. This has actually progressively increased over time as more people find out who I am and how I can help. And as a fail-safe to ensure that all eligible families are identified, I do try to screen lists of eligible cases that I generate from our database, Quincy. So, but the thing to keep in mind is that my involvement is not automatic. Unfortunately, someone needs to notify me about a case and ask me to become involved. So my main role, what does it entail? So a lot of what I do is explain the genetic results in a very broad way to the family and answer questions. So I am not a genetic counselor. I'm not a geneticist. I do not interpret results. None of us do. We leave that up to the experts like Melanie. I also, or as an organization, we generally tend to recommend follow-up testing for all first-degree relatives and explain the rationale and the importance for why we're recommending this. We provide them with detailed information about how to access follow-up testing and what that might look like. We connect families with the appropriate resources as needed. So currently we can refer first-degree relatives of individuals who have died from a suspected inherited arrhythmia or cardiomyopathy to one of these specialized clinics in Ontario. And lastly, we support the family's navigation through the healthcare system from referral to appointments at the clinic. So here's just a visual example of the differing stakeholders that are involved in the death investigation system, as well as the healthcare system, and how we all try to work together to support families and those at risk. So through my previous research, I have shown that first-degree relatives do experience numerous barriers when they are trying to seek out this cascade screening in the inherited arrhythmia clinics. So in June of 2024, the OCC implemented a recommendation that was provided by these clinics to us to simplify the referral process for these SCD families. And this is by having us directly refer first-degree relatives of SCD deceased persons to one of these clinics. So here's a screenshot of our referral policy. And so for me to be able to refer a family, I require them to complete some paperwork. So the first is an authorization form, which allows us to, importantly, release copies of all of these death investigation reports to these clinics. So you know what you're looking for, what was going on. If they have a family doctor, it allows us to send a copy of that referral to them. So then they therefore get all copies of the tests and consults going forward. And it also allows the clinics to send us consult notes back after the families have actually been seen. And then our second form collects demographic information about each patient so that we need to basically send these referrals. So as you can see, the number of referrals that we have been making since June 2024 has been steadily increasing over the past 18 months or so. And to date, we have offered 271 next of kin of 150 decedents direct referral to one of these clinics. Of these, 191 or 70% agreed to be referred. On average, each decedent has at least 2.7 next of kin that have been referred with them. 70 of these next of kin haven't responded to the offer yet, and 7 declined for various reasons that are listed. We referred these 191 next of kin to 19 different inherited arrhythmia specialists or clinics across Ontario with a 0% rejection rate. And of these 191, 61 have completed most of their cardiac and genetic screening. 35, we've received at least one consult note. For 19, we're waiting on the first consult note. 25 have appointments scheduled this year. 31, we're waiting to hear back about appointment details. 14, we're waiting to hear back about acceptance. And 6 were lost to follow up during this referral process. So here we can see the number of referrals by location, both pediatric and adult. So pediatric are on the left, adults are on the right. Not surprisingly, sick kids and some pediatric cardiologists in the Hamilton-Halton region are where we're referring most frequently. And then in terms of adults, we have UHN, London, Ottawa, and Hamilton as the most frequently referred to locations. So I've been tracking all of these timelines for my referrals, and here we can see a schematic of how long the processes actually take. So from the sudden cardiac death to when genetic testing is ordered takes about 4.6 months. And just note for all of these, there's a very huge standard deviation. After genetics are ordered, it takes about 3.7 months before I am able to reach out to next of kin. After I reach out to the next of kin to discuss the genetic results and direct referral process, it takes on average 46 days to have them referred, which includes the time of me waiting for them to send me their completed paperwork and me also drafting up and faxing off the referral letters. If we look at the time from when genetics are ordered to being referred, this takes about 5.2 months. And from the sudden cardiac death itself to the time that next of kin are referred takes about 10.1 months. So we've never really tracked these timelines before, like not ever. So this really gives us a good benchmark for how we're doing now and shows us where we need to improve in the future. So some demographic data on the 70 decedents. So the average age was 35.4 years and 68.6% male. Almost half of the decedents had a cardiomyopathy, while slightly more than half had a negative autopsy and toxicology, so presumed arrhythmic deaths. When we look at all of the genetic testing results from these decedents, 25% had a pathogenic or likely pathogenic variant identified, 41.4% had variants of uncertain significance, 17% had a negative result, and about 4% DNA extraction failed. And that's just currently at this time, as Melanie mentioned, these results are constantly evolving. Looking at the demographic data for the next of kin who we referred. So about 75% adults, 25% children, average age 35.2 years, 43.4% male, and this excludes 3 children that were referred under the age of 1. Just over a third were parents of a decedent, 37% were siblings, and about a third were children of a decedent. So what have the clinics found so far in the 61 mostly completed referrals? So 2 next of kin of a patient who died from dilated cardiomyopathy have the same phenotype, but genetics are still pending. 1 next of kin for a patient who died from arrhythmogenic cardiomyopathy has the same phenotype, but genetics are pending. 2 next of kin of a patient who died from a non-specific cardiomyopathy are genotype positive, phenotype negative. 1 next of kin who died from a sudden unexplained death has structural abnormalities pending further testing, and 55 have normal cardiac testing for now. So in summary, under the Coroners Act, the OCCO-FPS investigates sudden and unexpected deaths to identify cases with genetic disease, obtain tissue for DNA, and to inform families about their potential risk. The OCCO-FPS orders postmortem genetics on a wide variety of genetic conditions, and these requests for genetic testing are increasing rapidly as the field evolves. And lastly, the OCCO-FPS has established a successful referral program for first-degree relatives of sudden cardiac death patients, and we hope to expand this program to refer more cardiovascular genetic conditions later this year. Before I close, I just wanted to show a snapshot of what families are saying about my role and our direct referral system. I'll just leave it for a few seconds for you to read through. So I'd like to acknowledge a few members of both the OCCO-FPS who have been instrumental in the creation of both my role and direct referral system, and they include Dr. Dirk Heyer, who is our chief coroner, Dr. Michael Planin, who is our chief forensic pathologist, Dr. Chris Cunningham, who is our director of the postmortem genetic program, Dr. Joel Kirsch, who is a regional supervising coroner, Andrew Stevens, Richard Pang, and Dr. Paul Dorian, who started this entire journey for me at Unity Health Toronto. Thank you so much for your attention. I'd be very happy to answer any questions.
Thank you, Katie. That was amazing. And I think your involvement, yeah, Simon's clapping and so am I. Your involvement in this field has been amazing. And I really have to say that what I said originally about my respect for the Ontario Coroner's Office and progress in this sphere has been tremendous, and I'm actually really proud of that. And I think we're all proud of what you do because we hear those comments that you just made. I wouldn't mind it if Justin and Simon, who come from jurisdictions that are very different, Justin in Australia and Simon in the UK originally, whether you have comments on what it's like in other countries and other spheres in terms of the coroner's investigation. Personally, I think Katie's done an amazing job, and I think our coroner's office is to be congratulated.
Hi, Katie. It's Justin here. Thanks very much for the talk. It was great. I have one comment and one question. I think the comment is it's very impressive. I think the system that's available here. In Sydney, we do have a process to refer deceased patients for genetic testing, but it is not as robust and as streamlined as the process that you have. It's certainly nice. We do have a sudden cardiac arrest registry, and certainly there's attempts to try and biobank as much material as possible for future testing and certainly variant reclassifications. And perhaps that sort of leads me to the second part of my question, which is whether or not you've had any sort of families where there's been a reclassification of some kind after the original results, and what I suppose what processes are in place to kind of inform family members and things, in the event that there is say, for example, a reclassification from a VUS to a likely pathogenic variant.
Yeah, no, thank you for commenting on what it's like over there. It's interesting to hear what other people around the world are doing. Yeah, no, great question. And you're right, we're getting more and more amended reports back. We use Invitae primarily for the genetic testing. So, and a lot of the time, the coroners may have retired, and then, the regionals are dealing with this. So a lot of the time, we don't want to necessarily just mail out a copy, if it's 10 years later, which has happened. There was a family I dealt with right before Christmas where It was an unexplained death, and they had done the cardiac panel, and it came back upgraded to a pathogenic variant. So then we had to go and track down all of the relatives, which was quite a process. So fortunately, I think the contact information we had for the spouse was still existed. So we were able to talk to him because there were children involved. And then he was able to then put us in contact with her biological first degree relatives, so her parents and sisters. And so I've referred all of her biological, like her parents and sisters, just waiting to hear back from dad. But a lot of the time it's me sort of making that first phone call to families and being like, hi, you don't know who I am. We've never talked, and I'm here to tell you about, we've got this updated report. And I mean, the good thing is now we have this referral process in place. So if they want to be seen again and to be referred again, I can do that, which is what I did for this family, and I was happy to do so. So I'm glad we have that, because otherwise, it can be difficult for families to then try and navigate that on their own, through family doctor, and so yeah, we do have a fairly good system. We also have a template cover letter that we always send with the updated report that explains that this has sort of been amended and recommends what they should do, and has my contact information in case they have questions. So
thank you,
Katie. That's fantastic. When I wrote the agenda, when I put down the coroner's office leading the way in Ontario, maybe I should have said Canada. Maybe I should have gone wider than that. I mean, coming from the UK, I think the strength of the UK is because they have a nationalised health service. There's a framework that applies west to east, north to south, so everyone follows the same framework. And but still, you have the same barrier that once foul play has been ruled out, there can be some variation as to who actually then goes on to get further testing done. So, I think you made massive strides into standardizing the process. And I know that within Canada, actually, I don't think there's anywhere else actually that's doing this yet, as far as I'm aware. So well done, pioneering.
And well, I was going to say unofficially, I mean, so I do know Manitoba and Nova Scotia do direct referrals by their ME, their chief ME, I think, or one of the MEs does it. So we did actually talk to them to kind of get a sense of how they did it. But they also have much, much smaller volumes of
your volumes have gone up so significantly. You need another Katie. You're going to get too busy.
Almost, yeah. Like, so, I mean, like we ballparking numbers, like I'd say cardiovascular deaths, it's probably at least maybe 250 at least a year, and it's going up, and that doesn't include all the other ones. So, and we're about to expand the criteria again for genetic testing, and we're actually trying to expand biobanking as well on a lot more types of individuals. So yeah, life is going to be busy.
Katie, do you actually have a cutoff for an age at which a sudden death is a sudden death, but it's a bit variable, I tend to find? I mean, what's the approach in the office as to where they pick up a case or they don't?
Yeah, it's a really great question, because if they don't get reported to our office, we can't investigate, right? Generally the internal recommendations are sort of, young person, as I put in quotations, like 50 and under. But and the amount of autopsies, above age 50 is significantly less, right? So they don't always accept them. If somebody calls and there's a very reasonable explanation for why this person died and it's a natural death, then they won't do an autopsy. But I've seen it many times also in people in their 60s and 70s where it's been done, and then we found something, and then we've done genetics. So I mean, if you're really insistent, you can always just reach out to us, right?
I mean, your hit rate's very high. Your hit rate's what, 20, 25%?
The first time, you can always reach out to one of us. Maybe it's escalated.
I feel I reach out to you enough. I don't want to burden you with more work,
okay.
But you've been a fantastic person to work alongside. So, but I think the genetic hit rate's pretty high. 25% of your cases, you're getting a kind of, probably a key genetic finding in those cases. So,
but that's of the ones we've referred. It's probably less, like if I count everybody overall. But yeah, it's fairly high.
Yeah, that's impressive. That's impressive. Any other? We're stealing all the questions. Anyone else who'd like to ask a question? Please feel free to raise your hand or type it into the chat. Fantastic, very good. What's next steps, do you think, Katie?
Well, as I mentioned, we're going to be expanding our referral service to include thoracic aortic dissections are next that we're going to be looking at. And we're going to be expanding the amount of genetic testing and banking that we're doing on. We're going to be banking on all thoracic aortic dissections that we see. For all dilated cardiomyopathies, we're going to be banking and then testing on a lot more of them as well as myocarditis as well. So these are sort of next steps for this year.
You're gonna be busy. Okay.
We wait on you guys to let us know when things change, and then we try to adapt. So
okay.
Yeah.
Okay. That's phenomenal. Well done. Well done.
Thank you.
All right. We're coming up to closing time. Again, Katie, very grateful for you taking the time out of your holiday to join us. Mel, super grateful because I know that you're actually now in another session. So you're about to leave us and go to speak at another session. So you're in high demand yourself. So a huge thank you to you as well. Thank you, Dr. Green and Dr. Fan. Thank you for your co-chairing. That's been fantastic. I think we're pretty much up to time, so I'm going to close things there. Let Mel get away. And Katie, have a good holiday. All right. Thanks, everyone.
Thanks, everyone. Bye.
All right.
Thank you.
Thank you.